I think the most important thing is to provide the data, to know your epidemiology, and then to try to show the people how important it is to control the resistant rate and the use of antibiotics.
because you train the people, and 2 or 3 months later, the people move to another service. You need to train again, start again the process. It never ends. It's a problem for us.
Welcome back to the WSPID podcast series, brought to you by the World Society of Pediatric Infectious Diseases and the WSPID Antimicrobial Resistance Committee. I'm Professor Angela Dramowski, an infectious diseases pediatrician practicing in Cape Town, South Africa. I'm passionate about infection prevention and control and antimicrobial stewardship as tools to deliver better and safer healthcare for hospitalized neonates and children. I'll be your host for the second part of a special global series on success stories in neonatal and pediatric antimicrobial stewardship, where we aim to share experiences from around the world of clinicians implementing AMS in different practice contexts. Before I introduce our guests, we'd like to remind you to check out the global e-learning portal on the WSPID website for access to resources on this topic. Today, we'll be joined by two infectious diseases pediatricians from Latin America. A very warm welcome to Dr. André Ricardo Araujo de Silva and Dr. Fabianne Carlesse. A little bit about our guests. So, Dr. André is an associate professor of medicine at the Federal Fluminense University, Brazil, and is a visiting professor at Ludwig Maximilians Universität, Germany. His academic and professional expertise lies in the fields of antimicrobial stewardship, prevention and control of healthcare-associated infections, undergraduate medical education, antimicrobial resistance, and emerging infectious diseases. Dr. De Silva is the coordinator of the Teaching Laboratory for the Prevention of Healthcare-Associated Infections at UFF and serves on multiple guideline development groups convened by the World Health Organization. Our second guest, Dr. Fabianne Carlesse, is also a professor of pediatrics at the Federal University of Sao Paulo in Brazil, where she heads the infectious diseases group at the Pediatric Oncology Institute. She is also head of infection prevention and control teams, and her research covers a wide variety of infections in immunocompromised children, infection control, antimicrobial stewardship, antimicrobial resistance, and fungal infection. I'd like to welcome you both to the WSPID podcast and thank you for taking the time to discuss this important global issue today. Great. We'll start off with Dr. Fabianne Carlesse. Fabianne, why is antimicrobial stewardship particularly critical in neonatal and pediatric care today?
Hi, thank you so much, Angela, for your question. I think antimicrobial stewardship is very important for children and neonates because we have to use appropriately our antibiotics because if we don't do this, we can select resistant pathogens, and we know that the use of antimicrobials in children when we are facing a resistant pathogen is very difficult. And our population, this population, neonates especially, but also children, they are very vulnerable to develop severe infections. So if you do inappropriately the use of antibiotics, you can select resistant pathogens, or you can harm for some way these patients and promote more morbidity and mortality for these kids. So I think it's very, very important to do or to have a program of stewardship, of antimicrobial stewardship in this particular setting.
And Dr. Fabian, could you explain a little bit about how you do AMS in your hospital and a little bit more about the healthcare setting that you work in?
Okay. I am a pediatric infectious disease who works in a oncology pediatric unit. This unit is a reference center in Brazil, and we receive a lot of children from all the countries and even from Latin America. So I work with a vulnerable kids, and they use a lot of antibiotics. They are submitted to cancer treatment, and the cancer treatment, one of the adverse events is neutropenia. So this patient developed a febrile neutropenia, and we start with antibiotics. So it's very important to have a dedicated program for these patients because they will use a lot of antibiotics, and then we will change all the microbiome or all the flora of these patients, and then we can promote the development of infection for resistant pathogens. So in my hospital, we have close contact with a microbiology lab, with the clinical pharmacist, with the oncologist, and with the infection prevention control team. And we work together as a team to do the intervention early as possible. So if the patient starts with the febrile neutropenia, we follow our protocol. And then when we receive a critical result of the microbiologist, we change the antibiotics, or we do the escalation or de-escalation, and we have a very close contact with a clinical pharmacist. And I think it is very important when you work with vulnerable patients, because these patients receive a lot of other medication, chemotherapy, renal insufficiency, or liver insufficiency. So we have to work together to, because I think, Angela, the to do the antimicrobial stewardship is not only to use the appropriate antibiotics. You have to use the appropriate antibiotic, but you have to know the pharmacokinetics, the
Yeah.
pharmacodynamics. You need to individualize for each patient that you are facing. So it's very important to have a team who work together, and I think this is the way, this is the key for the success of antimicrobial stewardship program.
Thanks, Dr. Fabian. What about you, Prof. André, in your hospital? How has your AMS committee evolved? Tell us a little bit about where you work and the practice setting, please.
Thank you, Angela. Thank you, Fabian. It's a pleasure to be here. Yeah, the implementation of the antimicrobial stewardship in the hospitals that was planned for approximately before starting 1 year. So it was a time necessary to implement and to start only after discussions with professionals from the various departments of all our hospitals, including the high governance. It's very important to include the high governance to start the to support the decision that we do. And I think it's the same that Fabiana said. We involved professionals from pharmacy, from medical leadership, nursing, and every people that are directly involved in this process. And when we start, after start, it was necessary at least 2 months to observe how the program works in the practice. And only after this we started the fully uh, implemented the program. We defined at this time the following components. We listed 15 antimicrobials that was considered restrict
Mhm.
for considering our flora of resistance that mostly ESBL produces, and we implemented a prayer authorized and discussion with pediatric infectious disease specialists before the prescription, and only after discussion the antibiotic was prescribed. And that is a characteristic that the program works every day by week and every week of the year. So at this moment, it's impossible to start a broad spectrum antibiotic without a discussion with a pediatric infectious disease specialist.
Hmm. Thanks. So, as you described, really setting up an AMS program is a process. It's not an overnight success. We all know that. And maybe, Prof. Andre, you can tell us a little bit about some specific challenges that you encountered as you were setting up this program and how your team overcame those challenges.
Yeah, I maybe for colleagues, it's necessary to understand how the hospitals or the healthcare institution works, because you need to understand the people involved in the process. In Brazil, I think is not. We have a Brazil is a big country with different realities, but we have a problem in our institution by change of human resources. It's a problem because you train the people, and 2 or 3 months later, the people move to another service. So it's a problem. You need to train again, start again the process, and it never ends. It's a problem for us.
Yeah.
And but uh, in our hospital, we have like Fabianne hospitals, we have many children with cancer, and we have two institutional protocols that included febrile neutropenia and sepsis. And so, in only these situations, the clinicians, the physicians, could start the first dose of antibiotics without a consultant of pediatric infectious disease. But the second dose, it's necessary to discuss the case.
Mhm.
But it's a problem. I think our challenge is the change of human resources.
Staff turnover is a big problem everywhere in the world. And as you say, it's quite exhausting to keep repeating your AMS messages, but it's really important work that clearly never ends. So, back to Dr. Fabian, can you think of a standout initiative in AMS that made a substantial difference to pediatric health and outcomes in your hospital or region?
Yeah. I think we start our stewardship, antimicrobial stewardship here in my hospital, I think 4 years ago. And we have a lot of obstacles here. And we start with this pre-authorization, and it was in paper. And then we move on to the system. And the system is very hard because when you have the paper, it's hard because we need human resources to do the paper, go to everywhere. But when you have the system, we have other challenge because the system sometimes doesn't work. And then we have a lot of obstacles, and then we are putting it all on tracks. So we move it from the paper to the system, and now we have tough team. And then we realize that it's better if we put the lab uh, closer than us. So nowadays, we receive the partial result of the culture in our phone. And I think it
Ah,
is the
mm,
big, how can I say,
yes.
the big change, or
Yes.
uh, when you move forward with
A
this. So
shift, paradigm
shift,
shift.
yes,
Yes.
yes, this is, yeah, yeah. I think it was the big shift because now we receive in our cell phone from the lab the partial result, and then we can change earlier the antibiotics. Uh, Imagine with focus on spectrum and on agent. So we know that antimicrobial stewardship will have more than only the spectrum and the agents, but we can now, and it works on the weekends. So we have people who are receiving the result and is changing the antimicrobials. We started like 1 2 months ago, and we didn't measure the impact, but what I have the impression at it is a big shift. So we have many obstacles, and now I think we are better than the beginning.
Excellent. It's sometimes feels like a small change, but to the individual patient, that you make a life saving change in treatment, it really is a miraculous shift for the better. Great. Thank you for sharing that.
Yes. Just to give a little example, like when you are discussing in a big team on Friday even, and then our we have to know our epidemiology, and we have a resistance rate to carbapenem like 15% in my hospital. And when you have a critical patient, febrile neutropenia, start fever on the ward. So we need to cover this kind of agents. And when you receive the result that it's not a carbapenem resistant and you can shift the antimicrobial, I think it makes all the difference for this patient.
For sure. Absolutely. If you think back in the last 4 years, what you started out with AMS probably looks quite different today. How did you tailor your interventions to fit your local setting from a cultural, institutional, and resource perspective?
I think 4 years ago, I think we don't have the culture. I think it's the culture as knowledge, like it is important. We need to do this. It makes all the difference. And I think nowadays all people are doing antimicrobial stewardship. And last month in Brazil, the national surveillance agents, that name Anvisa, they release guidelines for pediatric antimicrobial stewardship. So it is a very important thing. Everyone is doing this. So now, but 4 years ago, it's not in our mind to do this. And then I think it's more difficult to change people cultures. Like we need to escalonate, we need to move. And for me, if I look back, it was very hard to do this. Everything is a problem. The paper is a problem, the visit is a problem, the patient is a problem, and it's very hard to do. So if I look back, I think the most important thing is to show the people the hospital epidemiology. So if you put in a word, in a warning, in a letter to all the clinics that we are increasing our resistant rate, patients with this kind of infection, the mortality rate is uh, very high, and then to start to put in the mind of the clinician that is very important to control the use of antibiotics. So you have to give them data. We have to give them numbers, and then they start to believe you. Because if you go there and say you need to change the antibiotics and no data, or the other thing, if you give American data, European data, Australian data, they say to you, it's not our reality. This is like Italian, they have a high resistance rate. So if you put the numbers of Italy here, they said, no, it's not our problem, it's their problem. So I think we have to give them data. And I talk with the people here. We have to provide the data. We have to look our data and we have to publish it. I did it in the past. I think I I don't delay 4 years to do antimicrobial stewardship. Yeah.
Absolutely. So personalizing the message is really key. I think I couldn't agree with you more that people need to understand how AMR is affecting their hospital, their patients, to really take it seriously and take the message to heart. So, keeping with the problem of AMR and difficulties really defining the best treatment for children with severe infections, Prof. Andre, what has been the role in your hospital of rapid diagnostics and laboratory support in your AMS efforts?
Yeah, there is no doubt that support of from the microbiology laboratories is essential for the success of the program. There is no doubt about this. Unfortunately, not all the healthcare facilities in Brazil and probably many parts of the world have access to this methodology, to the laboratory. But in our institution, we have a good laboratory that is our partner and that provides partial results 2 times a day, one in the morning and one in the end of the day about 5 p.m., 6 p.m. So it's good because you have access to this result and can change treatment of children at least 2 times of by day. But molecular biology, talking about a little bit about microbial molecular biology support, even less common here. It's not our reality, but in well-funded private hospitals, they have access because Brazil system is a mix of uh, a mix of care of patients. You have public care that cover all the people, but about 30-40% of population have private insurance. They pay a amount by a month and have a private hospital, private access, a different access. But we have also problems in private institutions because there is a physicians that read the charts of patients and so this exam I don't want to authorize, and so it's a problem. But in university, I work in a public university, we have access to molecular biology. So maybe it's a future, maybe it's a future, but not reality at the moment. And we include in this discussion a whole of artificial intelligence to maybe in next 2 or 3 years, or maybe before we have a important contribution of artificial intelligence for infection control and antimicrobial resistance.
Absolutely. I think artificial intelligence is really going to change how we do empiric antibiotic selection, triaging which patients most likely to have sepsis. I really think there are a lot of applications coming that will assist us both with AMS and hopefully IPC in the future. Um, Back to Dr. Carles. Have you been able to measure the impact of your AMS program, or have you got any plans in future looking at either how the program may have influenced clinical outcomes, length of stay, mortality, and so on?
We try to measure our antimicrobial stewardship program. We try to measure using the consume of antibiotics, doing how much antibiotics we use last month, and how much in quantity and how long we use it. so we can measure with this. The other factor that we use to measure the impact is the length of hospital stay. So if the patient stay very long in our ward, this is the second one. The third one is we try to cross the Clostridium difficile infection with the consume of anaerobic antibiotics like meropenem, that we use a lot of meropenem in my hospital because we have resistance rate to cefepime, that is our antibiotic of choice in our protocol of febrile neutropenia, that is 40%. So we use a lot of meropenem, and we try to measure the incidence of Clostridium difficile with this use of meropenem. Now with this critical result that we are receiving at the same time that it becomes positive in our phone, we are measuring our intervention, and then we will use this to measure the morbidity, mortality, ICU admission, length of stay, and Clostridium difficile. So, and our resistance rate. So now we are in other phase to use
Mhm.
this to measure this impact.
Excellent. I mean, as if the work of AMS is not hard enough, and then everyone
No.
wants you to measure it as well and prove that you really are making an impact.
Yeah.
But thank
Yeah.
you for all the new initiatives. And I'm so pleased to hear that besides measuring consumption and duration of antibiotics, you're also moving on to measure sort of some of the end points like C. diff and mortality and length of stay. That's great. So back to Prof. De Silva. You told us a little bit about your AMS multidisciplinary team, and we all kind of understand the involvement of infectious diseases and microbiology. But sometimes there are certain members of the team that are more difficult or slower to get involved in stewardship. Could you maybe talk to us a little bit about how you've involved nurses, pharmacists, and hospital management in your stewardship program, please?
Yes, in our context, our program, the program of my hospital is still led by by pediatric infectious disease. It's our reality, but we have inside the Brazil many other institutions that the program is led by pharmacists, like Hospital Pequeno Príncipe in Curitiba. It's a nice experience that a program colleague of our that is Fabio Mota and his team has a nice initiative, and this program is led by a pharmacist. But moving back to our hostel, all institutional decisions regarding adjustments to the program necessary how involve all healthcare professionals that are engaged in the process, including attending physicians. That's important that people, not the chief of sectors, but the physicians that work day by day, seeing patients, nurses, pharmacists, and the other people that work in hospitals, and all the challenges that we have during the month are discussed in a formal meet. We have a formal meet every month that to show the people the problem, the advance that points that you need to improve, and that's how the works here.
Excellent. Thank you for sharing that. Back to Dr. Carlesse. Do you have any advice for pediatricians who are either starting or trying to strengthen an AMS program in their hospital?
I think the most important thing is to provide the data, to know your epidemiology, and then to try to show the people how important it is to control the resistance rate and the use of antibiotics. So you need to have a good knowledge about your epidemiology and use antibiotic wisely. Then, if you are and know the epidemiology and work as a team, I think you don't do anything alone. It's very hard. I try it to do it alone as infectologist, as I am taking care of the children. I am infectologist. I know antibiotics, so I will use it. So you do not, you are not alone. If you try to do the things alone, you don't will succeed. So it's important to have a good team to work together and to know the epidemiology. I think is the key to success. Yeah.
Oh, those are great messages. And Prof. Andre, from your side, if you had to choose one key factor in the success of your AMS work, what would it be?
1K. It's
Yeah, only one.
just one.
You can give me more.
Yeah,
You can give me more.
yeah, persistence and perseverance.
Ah,
Yes.
good
Two,
ones.
two.
And how long did it really take you to set up AMS? I think you told me before it was many years of convincing the right people.
Yes, yeah, it's a challenge because I work with infection control 20 years for 20 years, and it was 10 years to understand the hospital, to convince the high governance to implement this process, because many high governors see the costs of a hospital despite the care of patients. So it's important to convince the high governors that it is important, and in many circumstances you will reduce the costs behind the care of patients.
Mhm. Absolutely. I think without the support of hospital managers, those that make economic decisions on where to allocate resources, we don't get far. And I'm going to write down your perseverance, persistence, teamwork, and knowing your epidemiology. Those are all fabulous suggestions. And Fabian, if you had to think of another one, particularly your program, other than the ones you've given me, what has contributed to success in Sao Paulo and your hospital?
Yeah, I love the persistence and perseverance. I think and patience. You need to be patient. The other thing beyond the work team, I think to listen. You need to listen the people who are taking care of the children. Here in my hospital, each group take care of a group of tumor. Like we have a leukemia group, we have the solid tumors group, and then we have to work with all these groups. And then I think you have to listen them because sometimes they bring some particularities of these treatments or of these children. And it is in my hospital, that is oncology hospital, but I think it serves for a general pediatric hospital, because sometimes you have ICU patients, you have a general pediatric ward, but you have a lot of chronic disease in pediatrics. So you have to listen the people who take care, who are in charge of these patients, because as we are infection control team, we are not in charge of these patients. We are helping them to take care of the children. So we need to listen them and work
Mhm.
team.
And as you were speaking, I thought there's one other group that we really haven't talked about, and I'd be interested, particularly in an oncology unit. Where is the voice of the parents in this problem of AMR? To what extent do parents realize what a life threatening problem AMR is for such vulnerable children, neonates, and children fighting cancer?
Yeah, I think you touch in a very interesting point, because uh, when you are a pediatrician, you have to work uh, with the family. We teach the mother to help us to understand the child, because I think no one more than the mother knows the child. So if you teach the mother that the antimicrobial is important to the child, but in a specific situation, you don't need to give them antibiotics if they don't need to. And I think each group need to do a special work with the families. We are trying to do this, to do a educational plan, to work with the families, to teach them that antibiotics don't solve all the problems. Sometimes we have other kind of infections like viral infection that we had a lot in pediatric setting, but and then we have other problems, and not all of them are infections. So I think it's very important to work together, the family. Yeah.
Great. Well, that's the end of today's episode, and I'd like to thank again Professor De Silva and Dr. Carlesse for sharing their experiences of implementing pediatric AMS in Brazil. To find further resources and educational content, you can visit the global e-learning portal on the WSPID website, which is your hub for pediatric infectious diseases insights. Thank you for listening to this WSPID podcast. Make sure you subscribe on your favorite podcast platform so you don't miss an episode. Please share this podcast with your colleagues, leave us a review, and be sure to tune in next time.
Thank you.